Okay. So I should go. Okay. Welcome and good afternoon, everyone. And we're so glad that you're able to join us for this very important presentation on the interventional strokes services that we now have at Munson and their new services, which is a phenomenal thing. Before I get into the actual presentation and introduce everyone, I want you to know that the presentation is being recorded. And if you have questions throughout the presentation, you can click on your chat function and then type those questions in, and then they will be answered later on in the presentation. Also, if you want to have your view, you can put your view on speaker view so that when someone's speaking, you will see that person large on your screen as opposed to seeing all of us, but that's just up to you. That's your choice. My name is Lisa Cooley, and I'm a member of the local PEO, which stands for Philanthropical Educational Organization here in Elk Rapids, Michigan. We are an international nonprofit organization that supports the education of women. We raise money and funds for women from seniors in high school all the way up to women who find themselves needing to go back for further training later on in life. Over 152 years, we have provided over $366 million to over 113,000 women. So it's no wonder that we wanted to educate not only ourselves, but the community about this wonderful capabilities that we have here at Munson. I also have a personal reason why I'm doing this. You see, my cousin's wife had a stroke last October, and she was taken to Munson. And while I was sitting with her son, waiting for the surgery to get over and to find out what her where she was with the surgery, I did what I normally do, which is I Google things. So I Googled Dr. Raja to find out who he was and what his capabilities were. And I soon realized that there were so many words after his name and his credentials that I just knew we were in the good hands, and we were in great hands. The other thing is, in my heart of hearts, I totally believe that without Dr. Raja and his team and the capabilities, that my cousin's wife would not be where she is 4 months after her surgery, that her quality of life is almost back to where it was beforehand, and that she might not even be with us. So I thank Dr. Raja and his team for what they did for our family. And besides that, I also like to share that Dr. Raja has a fantastic bedside manner. He was so kind to us when he got out of the surgery and answered all of our questions and really put us at ease. And so we are very lucky to have him and his staff and the future staffs that come here to Munson for this capability. So without further ado, I would like to introduce to our speakers. I'd like to first introduce John Cox, who is the Executive Director of Surgical Services. His responsibilities include MHC systems, surgical operations, trauma, and stroke. He has been with Munson for 5 years. Prior to joining Munson, he served in a variety of hospital administrative roles, as well as owned and operated a healthcare consulting company. John is a native Michigander. Dr. Gary Raja is an endovascular neurosurgeon. He joined Munson Neurosurgery last summer after completing his endovascular fellowship in Buffalo, New York. In addition to general neurosurgery, Dr. Raja brings cerebrovascular expertise for the treatment of stroke, intracranial hemorrhage, cerebral aneurysms, and more. And I hope I got all those right. In his free time, Dr. Raja loves spending time with his wife, Christina, and their 4 children, as well as running, cycling, and skiing. So let's welcome John and Dr. Raja to the presentation. Take it over.
Thank you. I'll get us started here real quick, and then I'm going to hand it off to Dr. Raja, who's going to share a presentation with you about our program. A couple of things. Munson Health System has been looking for some time at bringing additional stroke services to Northern Michigan. People always thought, well, you do stroke now, and it's true, we did treat stroke patients, but we treated them with medicines, with clot busters, and they have a limited effect on patients. Only about 10% of the patients' clots are resolved from a clot buster being used. versus having Dr. Raja and his team and skill set where they have much higher incident of being able to successfully resolve a clot issue during a stroke. So stroke is very much like heart attacks and traumas. Time is very important to treatment. And so, the quicker we can get to you and resolve that medical issue, the better chance for a good outcome. So this is something that Munson has been wanting to do, was preparing to do before COVID hit last March. And COVID, we had already brought Dr. Raja, we'd signed him and he was coming in the spring, but COVID put a little bit of a pause on some of our activities as we focused on the virus and treating those patients. But we were able to get the program up in August, and Dr. Raja will get a little bit more into that. But just wanted to share, and I've shared this story multiple times, but in talking to some of our team members and such, seeing a patient come in paralyzed, unable to talk, and then literally in some cases while they're on the table and Dr. Raja's treating them, they start to be able to move that arm again, be able to start communicating again. It's a medical miracle. And something that, stroke has impacted most people in some way. Most people know somebody who's been affected by stroke, and hopefully they've had a good outcome. But I think a lot of people know other folks who have not had a good outcome, who have been very limited functionally and maybe confined to a nursing home. It really is a disease that just devastates people. And so to have this service now close to home, versus sending them down to Grand Rapids, really, truly is going to make a difference, and already has made a difference for about 50 patients since we've started. And one of the things that I just want to leave this group with, and again, Dr. Raja will speak a little bit more on this, is that one of the things we saw when Dr. Raja came here before we launched the program is we looked at 3 months worth of patients, about 20 patients that we shipped to Grand Rapids for a stroke intervention from our emergency departments here up in Munson. And we found that by the time they got down there, only half of them still were going to benefit from an intervention. So only half of those patients that we sent were able to get an intervention and have the specialists down at Spectrum try and save those folks and resolve their stroke. And it really did create an urgency, COVID or no COVID, that we had to go, we had to move quicker. And so we partnered with University of Michigan to use their expertise and what they've already learned with stroke to help us ramp our program up quicker than we were initially thinking. And as a result, we know there's been quite a few patients that have benefited from getting that program up and running here. So we really appreciate that you would take the time to hear our story. It's an exciting story. I think you'll marvel at some of the technology and the skills that Dr. Raja brings. We're very fortunate to bring somebody in of his caliber to lead this program. So with that, I'll turn it over to Dr. Gary Raja.
Thank you, John, and thank you everyone for having us, for taking some time out of your day. I'm going to share my screen here and pull up a presentation. Can everyone see that? Display? Yep, good. Okay. Well, wonderful. Again, my name is Gary. I'm a Michigan native. I grew up downstate, just south of Big Rapids. Went to Lakeview High School. Did most of my schooling in Michigan. Went to Grand Valley in Grand Rapids, and then I did medical school at Wayne State, neurosurgery residency, 7 years in Detroit. Beyond that, at Wayne State and the Detroit Medical Center. And then I did a 1-year fellowship over in Buffalo at the Gates Vascular Institute, Toshiba Stroke Center, in open and endovascular techniques for cerebrovascular disease. And so I wanted to get back to Michigan, and was always kind of looking at where would I fit best. And, there were kind of numerous options in the lower part of the state where there were already established care patterns, established teams at Spectrum, University of Michigan, back at my home program, Detroit Medical Center, where there's numerous specialists similar to myself, or that people that cross cover from maybe the neurology specialty or interventional radiology, already there. And I said, well, I'd like to bring this service to an area that is not currently doing it and that needs it. And we'll get into that here in a little bit, but that landed me in Traverse City, and I've always had great appreciation for this area. In Buffalo, we did a lot of writing as well as cases, and so I've had the opportunity to co-author and numerous books and chapters and papers, and that's something else that I that's very near to my heart, is constantly innovating and bringing outcomes and clinical outcomes to light. This is a picture of the Gates Vascular Institute in Buffalo. It's just a state-of-the-art building where cardiology, vascular surgery, neurovascular surgery are kind of all located, and the two top floors are all research. And so that's sort of the background that I come from. And the University of Michigan has kind of offered us that ability as well through this stroke program to help with research and to contribute to clinical outcomes and research and things like that. And that's something we'll continue to do. We launched officially, so I got here in June, and we launched the program officially on October 29. That was World Stroke Day. That's when the media releases went out, but we had actually started doing stroke care. So ischemic stroke being pulling blood clots out of the brain with catheters for people having, weakness of the face, not being able to talk, weakness on one side of their body. We started those procedures in mid-August, just as John had mentioned. And so there was a learning curve, obviously, starting a new program at a facility. We had to train all the techs and nurses and do a lot of ICU in-servicing and those types of things. But we had everyone ready to go, and we were able to start in August, which was excellent for the community. This is why, I kind of decided to come up here in the first place, to Northern Michigan. I'll show you. If you look at this map here, when I was kind of researching places to go in Michigan and what the resources were in those areas, I noted this is the CDC, Center for Disease Control, U.S. government map of death rates due to stroke for those 35 and older by county. The dark purple color is the worst color. That's the highest rate per 100,000 people, up to 225 per 100,000 people. And when you look at Northern Michigan, you see a very clear band of dark purple running through it. This is especially compared with Southern Michigan, or below the knuckles. And I kind of looked at that and I said, well, that's odd. What is it about Northern Michigan that's different than Southern Michigan? And so when looking for answers, I came across this article in the American Heart Association journal called Stroke, which showed essentially which geographic areas have access for their patients in under 60 minutes to endovascular capability for stroke removal, for clot removal. And it was pretty clear that that area was, again, below the knuckles of the mitten, so lower Michigan. And so I said, this is where I want to be. I want to bring my services to this area, to a central area here. And, that was Traverse City's medical center, Munson Medical Center here, and essentially serve as the tertiary referral hospital for all of Northern Michigan so that this population of people also have access to this therapy. And that's what we've been doing. This is a map actually from last month, but each red dot is a patient encounter for someone who was treated here at Munson Medical Center just in the last 5 months for stroke thrombectomy. This is not every stroke that we've seen. That number would be, 90% higher than this. This is the interventional patients that underwent, clot removal here. And you can see that we have done exactly what we set out to do, and that is supply above the knuckles, Northern Michigan, with stroke care. And so I think this is a monumental achievement for the staff in the hospital, given that we did this in a pandemic and all of that, and are seeing good to great outcomes. We've now done over 60 thrombectomies, and that is in mid-August to now. So that's 6-7 months. So if if a patient comes into Munson, essentially they'll be either flown in or driven in by ambulance, or they can come in through the ED, or if they have an event in the hospital, they'll come. In-hospital strokes are a little different. We see them in their room, but if they come in through the emergency room, they'll come to our stroke triage bay. They will then be brought over to our special imaging suite, which will do some perfusion imaging tests that are very specialized in picking how much brain has passed away since the patient has had the symptoms, and how much brain is at risk of passing away, meaning that if we do nothing, what will a total stroke look like? So it's that at-risk brain that we want to save. Obviously, we cannot fix brain that has already died, but we can save the brain that's left, that's at risk, undergoing ischemic changes. And so we determine that in real time, actually. What happens is that scanner will take a picture, and the pictures are immediately sent to a special program on my phone and the rest of my stroke team's phone, the neurologist team, their phone. And we have then a stroke team that's also evaluating the patient down in the emergency room, in the bay, looking at what side of their symptoms on, how high is their stroke scale, getting a little bit of their history, and talking to family about the next steps. So it's a well-oiled machine to come in through this stroke bay. If the patient is deemed a candidate for clot removal, meaning we use a little catheter to go through the wrist or the leg and take it up under X-ray in one of these state-of-the-art biplane imaging suites, then we'll wheel them down to our interventional radiology lab. There the patient will find one of these new machines, which is called the Siemens Icono machine. It truly is state-of-the-art. It's, I believe, one of 7 or 10 in the country, and it's pretty amazing what it's able to do. Imaging quality and keeping the radiation dose low for the patient, myself, the staff. That's exactly what we need. So it has 2 cameras. The patient will lay on the table, and then I'll stand here and do catheter work here, looking at this screen while checking on the patient during the procedure. So good news is that we also have a second room, just like the first, coming online here, hopefully. And John, I'll let John speak more on that at the end of the presentation. So the next step here is looking at the images to decide who needs a procedure and who doesn't. And again, this is in real time. So as the patient's getting the scan, the data is being sent to myself, to my phone, as well as the stroke team, which consists of neurology, and our nurses and techs that work in the interventional suite. They get the same images I get, and I take a look at them, and we're able to actually communicate in a anonymous fashion, HIPAA compliant, through the app as well. And the app sends us pictures that look like this. It says red is dead. So red is tissue that has already passed away that we cannot save. But green is the area that will die if nothing is done. Essentially, the area that's at risk of dying. We call it the penumbra. So this patient is having a very large stroke that's affecting the left side. So they would be expected to be not talking, not able to understand speech, and not able to move the right side of their body, their face, their arm, their leg. This is someone who, if left untreated, would eventually likely end up in a nursing home or pass away. And if you can imagine, if they're a young patient, that could be 30, 40 years of being in a nursing home in a state not being able to swallow, not being able to speak, not being able to communicate. The worst scenario ever. And so, let's see. It's that type of patient that is the ideal candidate for this type of procedure. I just want to, I'll show you an example stroke here in a minute, but just to show you what the new imaging, looks like, take a look at this picture here and compare it to over here. This is a small stroke retrieval device. It's 2 millimeters, and it is in a 2 millimeter vessel. This filament here at the end is just a little bit bigger than a hair, and these wires are hair size. This is one catheter. This is another catheter. Look at how crisp and clear this is, and you're seeing this through the bone of the patient. This is the kind of imaging you need to make sure that a wire doesn't, doesn't go out something that you don't want it to go out, and that you're able to navigate and see everything that you're doing in real time. And so this is a type of quality imaging that you need to be able to do these procedures safely. You can imagine you're trying to push a small wire and catheter through a 2 millimeter vessel, using just the feel of your hands and looking at the screen and knowing where you're going. And so you need high quality imaging. If you look at this, you can see things are a little bit more grainy, blurry, and it's pretty clear why the new imaging is really serving our purposes very well here in Northern Michigan. Again, just to show you new imaging from old, look at how crisp these vessels are. These vessels are under 1 millimeter. These are like measured in microns. They're tiny. So to be able to see them this clearly through the bone is amazing. New procedures to date. This is actually out of date, as new as this presentation is. We're now over 60 thrombectomies. We're probably over 70 or 80 angiograms. We clipped another aneurysm last week, and we coiled 2 more. So these numbers continue to grow, and these are all patients looking at this that would have needed to be transferred downstate. So when you look, this is over 100 patients in just our short time here that we have saved a trip downstate and been able to provide a very high level of care in an acute setting, which is very important with stroke care. I'm going to show you here what this procedure looks like. This is not from here. This is a case from Fellowship in Buffalo. It is, I am the one doing it. I'll show you here. This is a 70-year-old gentleman. He could not talk. He was unable to move the right side of his body. So this is that special imaging. The red is the area of stroke. So he's having it on the left side. Show you this. So this is a CT scan that shows the blood vessels. And here you can see on the right side, the vessel, the carotid artery should come up behind the eye here. And then it branches to a middle branch, and it branches to this big branch that comes out over here, this vessel here. And this supplies movement and one whole side of the brain. When you look at the left carotid artery, you see that it just stops abruptly right here. There's nothing else over here. So this is a patient who's having a very large stroke. And so here, what we do is we access the leg. It's a poke, and we insert just a sheath. The patient, we try to keep awake for these so that we can monitor how they're doing. It doesn't really hurt. We keep them comfortable with pain medications. Here we are taking catheters up the neck. This is a jaw. So we're behind the jaw, moving up into the head. You can see a catheter being slid. And here you see that occlusion. There's no blood vessels over here, and there should be. So the blood clot's sitting right here. And this is what I was talking about, why you need such good imaging, because you're navigating very, very small devices in 2 millimeter vessels while sometimes the patient's moving. And so you need to be able to feel with your hands and see with your eyes in real time and be able to figure out where you are, what you're doing to do it safely. And so here we're bringing a catheter up to the clot. And now we're actually using a pump that's running out, the pump's out of the body, and we're using suction to help the clot integrate into the catheter so that we can pull it out. So next we'll pull that catheter back. And so the clot should be sitting in it. We'll slowly pull it back. We pull it into a larger catheter and pull it out of the body. And sometimes we have to do this several times. Here you can see the occlusion still remains. The blood clot did not come out. So now we need to go back up and do it again. So we go up again with the wire and the catheters. We bring the catheter back up, and now we're going to aspirate and pull it out again. And we have numerous devices, different catheter sizes. And, that's part of what we keep stocked here at Munson Medical Center is a device and a catheter to treat any type or any size of stroke. And there it's being pulled again. And so let's see here what we have. And so now it's clear that we've opened up the vessels that we never saw before. So now there's flow. But when you look at this, you say, well, man, that looks pretty narrow still. That's probably going to shut off again. And that's exactly what it does. Look at how narrow this is. And so now what we have to do is place a little stent there. So we're going to place a 2 millimeter stent in that area in the brain. to help keep the blood flow open in that area. And here you see the stent coming up. We're going to zoom in. We make sure we're lined up in the right spot with the stent. The stent's from here. The stent's from here to here. And there'll be a better picture of it opening here. It opens by inflating a balloon. And here we go. Here's the stent. This is the balloon that it's on. This is a 2mm device. And we're opening the stent. You can see it open there. And you can see the stent tines if you look real close. And so now we're going to do a run and make sure the vessel's open, that there's no bleeding. And it looks great. And I'll show you the final shot here in a minute. Let's see what this looks like. And it looks like a brand new blood vessel. It's nice and open. You have the flow that we didn't have before. Remember, the occlusion was previously right here. And so this is someone who essentially starts to get better in the hospital and continues to improve. And at 3 months, is walking, talking, fully functional, and probably has residual, minimal residual deficits, and has returned to an independent life. Looking at what could have happened to them had nothing been done, essentially they would have likely been nursing home bound. And so it's truly the opportunity to change someone's life. Let's see, this is a patient we did here recently from the Suttons Bay area, 56-year-old. She came in, her husband found her down that morning. We had her in the lab, I think within probably 3 hours of her having symptoms because she was so close. And her clot was here. There was no blood vessels here. We pulled the clot out on this device. This is the clot. It was about 1 centimeter in the blood vessel. And here you can see that now her blood vessels are nice and open and look good. And she, the next day, was able to walk and talk. She has a little bit of clumsiness with her hand, but that is even improving at this point. And she's back home with her family, enjoyed the holidays and everything. So this is her. She's been very open and vocal about the stroke program here and how it has helped her and her family. And she has allowed us to use her, her image and her story. Her story is on our webpage if you're ever interested in seeing that. We are doing a lot of outreach. We're giving these brochures out to our local emergency rooms across northern Michigan so that the word is out. Currently, right now, if someone has a stroke in Cadillac or Grayling or northern Michigan, I end up getting on the transfer line and talking with that physician and making the decision as to whether or not they need to be sent to Munson for further stroke care. And so that's going well. We're creating our own Munson stroke network here in northern Michigan. That's not all we're doing. We also treat hemorrhagic stroke, so aneurysms, which cause bleeding in the brain, AVMs, which cause bleeding in the brain. I'm a neurosurgeon as well, so I'm able to do that brain surgery, as well as use these endovascular catheter techniques to help safely treat some of these lesions when amenable, especially on the aneurysm side. So this was a small aneurysm that bled on a gentleman, and we were able to take care of that with this special stent. This is just some planning software, very, very technologically advanced software that we're able to use here to help plan patient-specific treatments.
Gary, can you just describe what aneurysm is to the group?
Yeah. An aneurysm is, if you want to think, take a garden hose and stick a balloon on the end of it. An aneurysm is that weak spot at the end, that balloon on that garden hose. And so when a blood vessel gets a weak spot, it inflates just like a balloon. And at some point, certain aneurysms, depending on patient risk factors, can actually burst, just like that balloon would burst, and bleed into the brain. And that can be very life-threatening. And so what we do is we can treat them with stents and coils. And I also do open surgical procedures through the head by putting a clip on them and removing the blood. So it's part of being what's called a comprehensive stroke center. We're able to provide comprehensive services here, and at some point we will apply for the actual, designation as we have, more and more cases here. So this is some of the other imaging software we have here. This is special ultrasounds that we use to monitor patients after their procedures. we're able to ultrasound the small vessels of the brain just through the bone. It's just gel, and you just set the probe on there, and we get a lot of information from that as well. This is another aneurysm that I was able to treat here recently in a lady this was found in. She had severe headaches, no bleeding yet, but you can see if this is a normal blood vessel size, that this is just waiting to kind of break open. This is much bigger than a normal vessel, and we treated that with a special stent and these coils through her leg, and she was able to go home within a day or two. So again, truly remarkable treatments here at Munson. We're proud to be, serving Northern Michigan, and I can take any questions you guys have.
While we're waiting,
I'll unshare my screen here too.
while we're waiting on questions, just a couple other statistics about our program. So bringing stroke to the medical center created about 26 new jobs for staff. So well-paying jobs in the community and some people with some very unique skills. So that was exciting. Also, we're bringing additional physicians in too. So Dr. Raja was the first stroke interventionist. We'll be bringing in a second person that will partner with him on this program. I really wanted to start with one person, getting it up and running. You can imagine that puts him on call 7 days a week, 24 hours a day. So luckily he's young, but that's part of what we're adding to this area with expertise on stroke interventions. And then I know the question will probably come up, these labs that you see there, we're the first to get them in Michigan and one of the first to get them in the US. So that's how new that technology is. But also just to give you an idea, one of those labs costs, the equipment alone is a little over 1.5 million for one of those labs. And then by the time we outfit the room with air handling and all the things that go in, it's about 2.5 million for each of those rooms. And we're putting a total of about 6 million into this program to get it up and running. So as Dr. Raja says, that second lab is on the way, and we hope to have it installed in late spring.
Well, John and Gary, it looks like we've got some questions coming in through the chat. And one question that either of you can answer is, how many people are on the team?
Wow. What do you think, Gary? There's a lot of people touch a stroke patient through the course of their treatment.
Yeah, initially in the emergency room, there's the emergency doc, someone from my service, neurology. So there's at least 3 up front, and then once you get into the IR suite, there's a tech, myself, 2 nurses, sometimes anesthesia. And then once you get to the ICU, there's a whole ICU team, neurology again, my service, nurses, ICU nurses. And then once you get out to the floor, there's rehab, physical therapy. So I'd say each patient is going to come into contact with probably at least 20 Munson staff employees.
Yeah, absolutely. The next question was the name of the equipment. It's called the Icono biplane, and it's made by Siemens over in Germany. Gary, the third one, how long does it take to get a patient in the biplane and get them ready for a procedure?
So from the time they come into the emergency room, they'll be assessed quickly. They'll get a scan. That's usually under a half hour. And then they'll be in the biplane suite if it's a go, probably within 15 minutes or so. Once they're in the angio room, the team usually has them ready in under 10 minutes. It's essentially moving them over to the table, prepping the area and draping them with a big drape. So not long.
And these rooms are located in our radiology department, which is on the first floor, very close to the ER. So when the University of Michigan stroke specialists were here, they were very envious, one, of the equipment we were getting, because it's better than the equipment they have at University of Michigan, but 2, distance to travel for our patients is pretty short compared to being at one of the larger facilities downstate. So things are just closer together at the medical center, and that's a real benefit for us.
I guess, John and Gary, perhaps one of you could maybe discuss that comprehensive stroke center status and why that is a goal of Munson to attain, and maybe exactly what that takes to obtain that status.
Dr. Raja?
Sure. So the Joint Commission is an independent governing body nationally that goes and certifies different facilities, different hospitals with this certification. So currently we are what's called a primary stroke center, and Munson has been certified as a primary stroke center, able to give clot busting drugs like TPA since I believe 2012. What it takes to go to the next step, which is kind of where we are now, is what's called a thrombectomy capable, meaning that we do this procedure. That's kind of an interim certification that you can get, but the gold standard and what you want to be if you're a tertiary referral center, which is what Munson really is for Northern Michigan, is you want to be a comprehensive center. And that's a center that takes care of both ischemic, a blood clot in an artery causing the brain to die, as well as hemorrhagic stroke, which is those aneurysms and AVMs that we talked about earlier that cause bleeding in the brain. So for that, you need to have a neurosurgeon that can do brain surgery. You need to have an endovascular surgeon that can do the endovascular strokes. And then you need to have a huge team around them. Essentially, you need to have a neurology service that can see all these people in the beginning and the end so that you can track their outcomes throughout their course. You have to have huge amounts of data mining, which is what the University of Michigan will help us with, so that all of these metrics that they need tracked, such as like blood sugars, blood pressures, NIH stroke scores, when sub-Q heparin was started, all those need to be tracked. And there's probably, 100 of them or so that need to be on every patient checked off and in a box and in a database that's searchable. These are some of the infrastructure things that Michigan Medicine will help us with. Beyond that, you need staff. You need not only nurses and nurse practitioners, physician's assistants, but you need neuroradiology staff to be able to read the scans, which we have now. But then you also need ICU staff. You need neuro ICU people. You need critical care people. You need a full pathway of stroke care from the beginning through the end. And so that is something else that Michigan Medicine is helping us to design. As you know, they've already done this and helped similar size hospitals down in Grand Rapids, Metro Health. Beyond all of that, there's some special conferences and teaching that you need to show that you're doing. We're already doing those things. We have a conference, a stroke conference already. And then research, research is something that's near and dear to my heart. And so that is something else that we will be doing as well with the University of Michigan. So there's a lot that goes into that certification. And that's something that you can apply for kind of once you've been up and running and can show your volume. So.
One thing that I think is very interesting is beyond stroke interventions and neurosurgery, Dr. Raja uses a lot of the endovascular techniques to do other kinds of treatments that weren't available in Northern Michigan before. One of them is where he actually introduces an artificial clot for medical purposes. And I wonder if Dr. Raja, you can talk a little bit about some of those procedures and how those help patients that wouldn't normally get that kind of care in Northern Michigan.
Sure. Yeah, I think patients, there's other things that we're able to do besides stroke with these techniques. One of which is patients with bad nosebleeds, who we recently had a couple of these now, nose or throat bleeding that's so copious that they can't really breathe, or that they have to have things inserted in their nose to try to hold the bleeding, but that's very uncomfortable. We're able to do an awake procedure, minimally invasive, again, a poke on the wrist, catheter goes up. I can find those arteries that branch from the neck and go to the face and the nose. And I'm able to put little tiny blocking particles there to help slow or stop the bleeding. The few patients the couple that I've done here, those patients have been able to get that very bothersome packing out of their nose and essentially go home the next day. And so, that's just one way that we're able to improve people's quality of lives with these similar types of procedures that are all kind of related to the field that we're in here.
Gary, there's a question here. If a person takes a full-size aspirin for factor V, will it affect their outcome if a stroke occurs?
So I guess, factor V, and, the purpose of today is I don't want to hand out, we don't want to hand out medical advice, but the factor that makes people prone to having blood clots, which can definitely cause strokes. Usually, if someone has had an event due to factor V, they would be on some sort of what's called anticoagulation, not just aspirin. Aspirin is an antiplatelet. And so, I think that question's better assessed, obviously, by a primary care provider who's looking over the patient. But an aspirin in general has been shown to help in some situations with stroke. I'll say that. But
any other questions from the group?
There are no other questions. I would just like to thank John and Gary so much for your time, your talent, your capabilities, what you're bringing to the area. We all know it's a special place, and you made it even more special by bringing your capabilities here and making sure we have a good quality of life. So we thank you so much. If anyone wants to sign off now, they need to. That's the end of this presentation, but I know John is going to talk a little bit more about how we can help Gary and John continue on and getting this equipment and building the teams so we have this excellent care. And the other thing I'll just say is as we said, it's recorded. If anyone wants a copy of the recording, you can contact me, and it's LLC at llcpeo@gmail.com, and I will send you the presentation so you can share it with other people to help educate them as well and continue to spread the word. So again, thank you, Dr. Raja and John, for your time. It's very valuable and we appreciate it.
thank you. Thank you.
Thank you.
My name is John Gower, and I'm with the Munson Healthcare Foundations. Many of you probably received an email from me at some point, either Monday or today. But I just want to close today by saying thank you so much to both Lisa and the PEO organization just for hearing Munson's story related to our stroke effort here. And, I asked a few things. One, if you're able to support this, give you a little background, we're attempting to raise a little over $5 million towards the overall cost of this project, which is actually an $11 million project. So we have a fundraising goal of a little over $5 million. And I do want to announce today, we're excited that we've had 2 anonymous donors from the Elk Rapids area that have challenged us with a $40,000 gift for any Elk Rapids community members that would like to support the project. They will match that up to $40,000. So I will state that, and we're excited about that. But even more important, help us spread the word. We're certainly excited, if you can't tell, to have Dr. Raja and John Cox here, and just helping spread the word about the effort that they're putting in place here at Munson Medical Center and really in Northern Michigan is so helpful to us. If you're interested in things like this, we're constantly looking for new avenues of spreading that word through presentations. So certainly reach out to us and let us know, if we have an opportunity like that. And lastly, we're going to be sending out an email tomorrow with a survey. We just ask that you take that and let us know how you might want to connect, whether it's when this technology comes on board fully and we're able to do tours and bring folks here into the hospital safely. If you're interested in that, let us know that. But also continue using Munson services. We're truly grateful to our community, and during this pandemic, we've been humbled and blessed to have the folks reaching out to us and saying, how can we help? So thank you, and look for an email tomorrow, and have a great rest of your afternoon. Take care.